Okay, Dr. Kahal, uh, as Christiana Care's HIV PrEP expert, talk to us about the follow-up. Yeah, put you on the spot.
8 months into the job. Thank you.
Right, you are welcome. Well, and in that PrEP is relatively new. I think we're all learning the details on this and becoming experts together. What about the follow-up testing required for PrEP users? Have you heard of any problems from your patients about their healthcare insurance refusing payment for the follow-up diagnostics?
So, at least at the Annex, we're offering PrEP at the Annex as well as some of our satellite sites. And so, to date, we've had close to 20 patients scheduled to come in for an initial appointment. I'd say about 15 of whom have actually shown up, and 100% of these patients have actually had Medicaid. And so for us, that has not been an issue yet to date, but it is something that as more and more patients are referred to us and we train providers out in the community to evaluate and prescribe PrEP for patients, that this will become an issue. So we personally actually have not encountered this particular issue yet in the 6 months that we have been rolling out PrEP through the Annex.
And what kind of patient feedback are you getting? What are the real-world Wilmington concerns that patients are expressing?
So again, with the caveat that we're very much sort of in the infancy of developing this program, we don't yet have a single patient who's come upon their 6-month appointment. And what I would say to date for us, most of the patients who we've seen, a large number of them have either been partners in a serodiscordant relationship. So a majority of the cases, their partner may already be a patient who's HIV positive and enrolled in one of our clinics and have heard of it through their partner or just through coming to visits with them. We've had a couple PEP to PrEP conversions, which have been really, really great. And then we've had a couple patients kind of fall within the bracket of the, I would say 20 to 30 young MSM. And those patients have actually come to us largely through word of mouth through the community. And so I think for us, we're still at the stage where we're really still trying to get the word out to those who are at the highest risk. And you have to remember that our program at our PrEP program is nested within the HIV program at the Annex. This is the largest HIV provider in Wilmington. And so there's that association. And so I think a lot of the patients that we're really trying to reach because of our physical location aren't coming into us. But we've been getting a lot of positive feedback actually from our HIV positive patients who are now aware that we offer PrEP, and they're spreading the word through their local communities. And that's just been a really, really wonderful thing to see unfold.
All right. And so question that could go to Scott, to Tyler, to Peter, any of you with the consortium or with AIDS Delaware, chime out and tell us what public health engagement efforts are your organizations doing now to supplement the work of the HIV/AIDS clinic and that word of mouth that's naturally happening. Go, Tyler.
So like I said, a lot of our partnerships are through AETC, a lot of word of mouth as well. After we finish this summit, we're going to be entering a phase of community engagement and involvement in education. And so I think after this summit, hopefully we'll get prescribers through this summit, but then we're going to be entering our education phase. Am I missing anything else, Scott?
I know Pat Lincoln's going to be doing education this afternoon about the toolkit, and she'll do an awesome job. I know that. The website that you guys have put up is actually starting to generate community referrals. We've gotten a number of people who have called based upon the information they've gotten. I don't know if Linda Dean, who's our nurse practitioner in Georgetown, can lend a little light about what's going on in Sussex County as well, but I can say that I think the word is starting to spread, and I have to agree. I think a lot of that word is coming from HIV-positive patients who are in the community and are saying, hey, this is something that you need to be aware of.
Yay.
I'm Pat Lincoln, and Part F of the Ryan White program is the AIDS Education Training Center. So when you hear AETC, it's the AIDS Education Training Center, Part F of Ryan White. I find that I get a lot of phone calls in my office from private OBGYNs, and it's mostly what we've heard this morning so beautifully about the discordant couples. One scenario that goes on and on and on is a woman who's sitting in front of the doctor crying. She's been married for 20 years. She just found out for the past 12 her husband's HIV positive and hasn't told her they haven't had protected sex. What can I do? So my heart always sinks. And first we have to get counseling, we have to get an HIV test. But now we have something to offer if she is negative. And what I think is really important too is the PEP to PrEP. So if she's just had a recent exposure and we can start her right away and give her hope, it's great. So for the discordant couples and for couples who want to conceive, because you heard this morning, and you may not be aware, but sperm washing works, but it is extremely expensive and it's almost impossible to get a discordant couple. You have a female who's negative, a male partner who's positive. She wants desperately to have his child. Sperm washing works, but it's extremely expensive. It's really hard to get into, and unless you have a research project somewhere that you can get into, or unbelievable insurance, it is really, really expensive. So to be able to offer the private OBGYNs, and I am really thrilled that the women are included in this discussion today. Thank you for listening.
So just one quick follow-up on the question to Dr. Kahal. So if you do see patients with private payer insurance, some of them will reject follow-up lab testing if you're screening every 3 months. However, not to be discouraged, there are really creative ways. You don't necessarily need to screen every 3 months, so that can be up to you and up to the patient. The other thing is you can have your patient go get their labs done at a federally qualified health center, for example, months 3 and 6, and bring those back to you. You can have your patients go get their HIV tests done at free clinics. So there are those create extra barriers, right? But they're not $800 lab bills, which are giant barriers, right? And so I think that be warned that sometimes it is worth you as a provider, or if you have a navigator, if you and it's plan dependent. So many plans do cover all of the screenings, but there are wonky plans out there that don't, which can send a very alarming bill home to your patients that are very expensive. So be mindful of what you're ordering. You can maybe screen, depending on what's going on, one site, or I think so one size does not fit all when it comes to private commercial plans, because I think what we know with the healthcare system is private commercial plans are not in it for our patients, they're in it for themselves. And so so be aware of that, and I think that's really important, and so that is just to name that. But Medicaid's, from my experience, and it's been similar to Dr. Kahal, will cover everything. So
I wonder if Highmark Insurance heard that clap. Just wondering. This is a general question. Anyone can field it. Have you experienced resistance and bias in the provider community about PrEP, and what are the successful strategies for overcoming them that you could suggest? We all understand this is very emergent in Delaware, but what are the strategies we can do with the docs who or the NPs or the PAs who just don't really feel that this is a discussion they want to have?
Well, I have to say, to date, at least within the Christiana Care Health System, I've been massively impressed at how interested primary care providers, who really are the people who are serving, at the front line for these patients, how interested the providers are in learning more about PrEP, and have actively actually come forward to us to sort of engage in a collaborative effort to really get PrEP out of the HIV clinic and into the community. And so we're actively working on many collaborations, and actually just having the statewide consortium it's a perfect example of a wonderful effort to bring together all sorts of providers, and namely primary care providers who are out there in the community who want to be doing this work, and they just need access to the resources to kind of take that first step to make it happen.
Do you want to answer?
Dr. Smith.
There were 2 lessons that she had about how to get providers on board. One was initially they started by going to like the chief medical officer or whatever. And while you do need that person to at least be okay with it, that was turned out not to be a very efficient way to get people on board. The second thing was there were some providers who were older, and she gave the example of somebody who was 2 years away from retirement, who just didn't want to do it. And they said, okay, fine, you don't have to do it. But the younger providers were very much more interested in learning how to do it. But they needed a lot of hand-holding, and especially as they saw their first few patients. So they were willing to try it, but it was a very kind of ginger, okay, if you say I can do this, I'll try it. But they needed somebody to talk to, somebody to come back to them and say, how did it go? Are there questions? Is there something, that you would do differently with your next patient? And after they've had that hand-holding for the first 2 or 3 patients, then they were pretty good. So that's what she said yesterday.
Dr. Smith, are there any CDC supported or created, motivational interviewing courses that people can take so to specifically kind of mock up having these difficult conversations?
Not specific to PrEP. However, I'll talk when I talk at lunchtime about some of the resources we do have, but that's a really good idea.
All right. Up front, Scott, or here.
I just wanted to add, I think we talk about primary care providers, one group that they're not traditionally considered primary care providers, but we've found is really important to include in the discussion is emergency medicine physicians and clinicians. So we had 2 patients of ours who are on PrEP. One was a young man, one was a young transgender woman who went to the emergency room for reasons unrelated to PrEP. And because they were on Truvada, their ER discharge records read HIV positive. And both of those kids freaked out and, this is on my record. Someone else is going to see this. And, we were really concerned because, of course, we don't want stigma and negative ideas to come from us as clinicians. There's already enough in the community that we're sort of battling. And so, I think that is a really important group to target. We were able to, we wrote a letter, Caitlin and I, to both of the directors of the emergency rooms at these 2 separate hospitals offering trainings, and we didn't hear back with any interest. But I was able to track down one of the ER doctors that took care of our trans patient and just spoke with her directly. And she was actually very well-meaning. It had been an honest mistake, and she was really eager to learn. And what she said was, honestly, HIV medicines are very confusing now because it used to be that if someone was on 3 pills, we knew they were on HIV treatment. And if they were on 1 pill, now you guys have all these single tablet regimens for treatment and we have no idea anymore. So we just see, HIV medicines, we think someone's on treatment with a single tablet regimen. So there was a big request to us to do some targeted trainings towards emergency rooms for that reason.
There's a question in the back.
For you, anything.
So working downstate in a community that's primarily community physicians and private practices and a dearth of community, federally FQHCs and that kind of thing, talking about PrEP means talking about sex. And talking about sex, maybe kinds of sex that the provider doesn't have. And when you are scheduled 2 patients every 15 minutes, there is the perception that you can't unpack all of that in 7.5 minutes, no matter how comfortable or uncomfortable or knowledgeable or not knowledgeable you might be. The current healthcare model really argues against that. And so add that to HIV medicines are perceived as being very complex. There's a real hesitancy for local providers to get involved with it, even those local providers who think it's really important. And so I think it argues that we need more public health funding in these situations.
Dr. Luta, are you still here? I would be remiss if I didn't ask Dr. Luta to respond to that in terms of the public health funding and what opportunities might be coming our way.
Thank you very much for that question. And it comes.
No one is safe.
It comes at an interesting time because I've just come from a meeting where the CDC is thinking of consolidating our prevention funding with our surveillance funding. I'm hoping we'll come out of this better off in terms of the level of funding that we've been getting. Having said that, I think your points are very well taken, and we'll use whatever we have at this point, especially working with Pat Lincoln up front, to see how best we can reach some of these providers and help them in approaching some of these questions with their patients. We have taken note. Thank you.